Shop COVID-19 in schools. The district buildings are closed to the public during the current state of emergency. To listen to the live audio stream of the meeting, please click the link provided on the Greenville County School homepage, www.greenville.k12.sc.us. I would like to thank our doctors here today for their time. And I could spend about 30 minutes on your bios, but I'm gonna just briefly say a few words. Dr. Eckard, thank you so much for being here. Professor in the Department of Pediatrics and Medicine Division of Infectious Disease at the Medical University of South Carolina. Dr. Eckard serves as for pediatrician, and I will tell you there's one thing about Dr. Eckard that I find very, very interesting and appreciative. Dr. Eckard is working with other leaders at MUSC to maximize hospital operations and treatment guidelines for children with COVID-19, and is teaming up with the South Carolina schools to implement risk mitigation strategies for safe and in-person learning. Thank you so much. Also, we have Dr. LaCroix, and Dr. LaCroix is practicing pediatrics infectious disease at the Children's Hospital, and she is the chair of the Department of Pediatrics, Medical Director, Children's Hospital with Prisma Health. Thank you so much. And also, we have Dr. Blackstone, who's the Senior Group Physician for Primary Care. He's the Chief Clinical Officer for Secours Health System, and I can't tell y'all how much I appreciate y'all being here, especially on behalf of the board, because we have so many questions, and I will not delay any further. I will turn this over to Dr. Royster. Would you like to say a few words?
No, I don't want to take away from their time other than to express our appreciation for them being with us today, and we look forward to hearing what you have to say. Thank you.
All right, so who would like to go first? Dr. Eckard?
Okay. I actually have a presentation to give, and then we've got some questions from the board, and I'm going to moderate a little bit and turn it over, the answers to those questions, to my colleagues here. It is really my pleasure to be here today. I typically don't give talks sitting down, so this is kind of a nice thing for me. I'm usually wandering around, so hopefully everybody will stay awake. But what I thought would be an important thing to do is to maybe put everybody on the same page. So I have been doing COVID work basically every single day for the last year, as I'm sure the people sitting beside me have as well. And it is very complicated. It changes very rapidly. And sometimes it's hard for everybody to keep up with the intricacies. So my hope today is to catch people up, if you will, with the current data, where we are with various things. And my biggest goal is to show you the data for schools and keeping kids and staff safe while in school. And I have to figure out how to advance my slides. There. So those are my children. And while I have no agenda except to keep kids safe and the community at large safe, I'm a scientist and a doctor, and I am very science oriented. I don't have an agenda in terms of taking the data and making it to be whatever I want it to be. My opinions change based on what comes out in the literature, and some things that we thought were true last March are no longer true. And so at this moment in time, I have been following this very closely for the last year, and children need to be in school. And I'll show you some evidence to tell you why. Children are safe at school, as are the teachers, if appropriate mitigation strategies are in place. And we'll talk to a great degree about all of that. There is nothing that we can do short of being in a vacuum that is risk-free regarding COVID and life in general. But you will see from what I have compiled over the last couple months that activities outside of school are a much greater risk to individuals than what happens inside the school. The in-person learning in this modified setting is not ideal, but it is essential for the safety of everybody, is better than virtual learning. And children are resilient, and there's no evidence at this time that the mitigation strategies that we put in place in the schools are adversely affecting the well-being of our children. And I say that as a doctor and as a mother. So a little bit of background is that if you haven't figured it out, COVID is very serious and has really caused catastrophic morbidity, mortality around the world. South Carolina in particular has been hit very hard, especially when you consider the overall numbers in South Carolina. Much of South Carolina is very rural, and many hospitals have really struggled to keep up. You know, you can read one newspaper article and think you understand, but remember that most people have an agenda. And if you only present half the facts, you only get half the story. And so it is amazing to me, because of where we sit and we see people dying every day, that I still have neighbors, for example, who don't know a single person who's had COVID. And so it's a little bit about where your perspective is. But I'm able to look globally at all of the data and can tell you that it is very serious. It is much more serious than our typical influenza years, and is really a very novel virus with implications that we have not previously seen in our lifetime. So you can see here, South Carolina, the death rate by county is on the right-hand side. And I understand that sometimes it's very hard to understand some of the data. These are people who really have died from COVID. Some of them may have had underlying problems, but they didn't just happen to have COVID at the time of their death. These are confirmed by DHEC as COVID being contributing to the actual death. And you can see that's Greenville County. You all had a bump in the summer, as did we in Charleston County. But since the holidays, it's been just unprecedented numbers. We are on our way back down, but they're still very high. When you look by region, some regions have struggled more than others for a variety of reasons. So you do have to take into account some of the regional differences. So as I mentioned, it is true that people who are older and those with underlying conditions are more likely to die from COVID, but many of these conditions are very common: hypertension, obesity, diabetes, where many Americans have them. So take that into a little bit of consideration, that many of you, even in this room, may have some of these underlying conditions, and even young people can have some significant complications related to COVID. That said, it is true that most people recover within a few weeks. Even my own family members had COVID. I had one close family member who was in bed for over a week, and then with time, he did completely fine. But there are some people who even have mild symptoms initially who end up for weeks or months with longer term symptoms. And we're not sure why some people have those and some people don't. There's a lot of things we still don't know about the virus. In a recent review, they had listed more than 50 long-term effects related to COVID. Not every person has all of those effects, obviously, but at least 50 have been ascribed to COVID. The most common ones are fatigue, headache, attention disorder, hair loss, and trouble breathing. Again, this is not the majority of people, but it is hard to know who's going to have some of these long-term problems. There's a lot we still don't know. And I say this, and you'll see in my next part of the talk, this is not meant to scare you. It is meant for you to have a healthy appreciation for this virus. This is not a normal situation for us. And so in order to keep everybody safe, you have to understand some of the implications of getting the virus, for some people. So I'm going to talk a little bit about COVID in children. So children of all ages can get COVID. We have seen it from infancy all the way up. And as time goes on in the pandemic, more and more children obviously are infected. In general, children with COVID tend to have very mild illness, but severe disease can happen even though it's rare. And I'm going to show you data from MUSC of who's been admitted in the pediatric hospital. So the title of this research article is only there to show you that we are still learning about this virus. And in this particular study, they looked at a bunch of children who had minimal or no symptoms at all. And when you looked at their blood markers for inflammation and for clotting, most of those children had abnormalities. Now, we don't do that in a lot of other viruses. So it's possible that other viruses like influenza cause similar abnormalities. We just don't always look. But for this particular study, they did find these. And I think the part that is most important to know is that probably most of this goes away, but we don't know yet. So it is not the right attitude to say, oh, it's not a big deal if my kid gets this. Most will do fine, but not everybody does fine. So you just have to be respectful of trying to keep everybody safe. So I've looked very closely at all of our patients who have been admitted over the last year. And there's a number of reasons why I looked at this. We've kept lists basically from the beginning part of the pandemic. And I've looked very closely at every single child who's been admitted. So these are not children who just happen to have a COVID positive test. I've excluded all of those. These are people, children who have come in with symptoms related to their COVID. Now, in many cases, it is not the COVID that gets them admitted, it's an exacerbation of their underlying problem. So for example, you have a child with asthma, you have a child with sickle cell disease, you have a child with diabetes. Those children are at a much higher risk of having not only severe COVID, but having a worsening of their underlying problem because that COVID infection just tips them over the edge. So we have had a few children who really have developed serious disease specifically related to COVID. And in most of those cases, they are children with altered immune systems, such as they've had a transplant, they're on chemotherapy, and sickle cell disease has also shown itself as a marker of having more severe disease. Interestingly, we've actually had 3 healthy children with no problems before, and their presenting symptom was new diabetes. And I have talked to other people around the state, including Dr. LaCroix, and others are seeing the same thing. Maybe those children would have already developed diabetes at another time with another illness. It's hard to say, right? But this did tip them over to this new diagnosis. And it is just important to understand all of these intricacies. We always hear, oh, all the children do fine. The majority do fine, but not all of them do. Children with special needs are also an important group because many of them, such as those with Down syndrome, for example, also have problems with their immune system. And so those children we have seen also have a lot of problems when they get COVID. So I broke this down a little bit by race and ethnicity and age to show you that there is not one group that just gets admitted among the pediatric population. It is across the age range. But what we have seen is that African-American children are at an increased risk of severe COVID and of being hospitalized. And many of these children who are at risk for severe COVID are those children who need to be in school, either because they're getting services at school like speech therapy or mental health treatment or hot meals. But those are also children who are often at risk for educational disparities. So we have to protect these children when they're in the building. So I will say, sometimes people talk a little bit about sudden death and myocarditis after COVID in children. It's exceedingly rare, but it is there and there is a risk. And this study looked at 26 collegiate athletes, and 4 of those 26 had abnormalities on their MRI suggestive of myocarditis. And those children, young adults, all had mild or no symptoms related to their COVID. So again, just to tell you that there are things that we still don't know about it. I would be amiss if I didn't mention MISC or MUSC, because we continue to see life-threatening illness in our hospitals. And many times the parents tell me that they had never even heard of it. So I am on a mission to really educate families and providers about this, because what we have found is many of these children present to outside hospitals 1, 2, 3. I had one child that had gone to the ED 5 times before anybody even considered MISC. So it's a post-infectious inflammatory syndrome. So a lot of times children have no idea that they've even had COVID or that they were even exposed to somebody with COVID. Almost all of these children are healthy, completely healthy, and then develop a very high fever. And if they don't seek medical attention and are recognized as MISC, they really can develop life-threatening infections or conditions, rather. It's not infection. And almost all of them need to be hospitalized. So what happens is they see their provider, they see their emergency departments. It looks very similar to other viral illnesses. And then by the time it is recognized, they are near death. And Greenville had a recent death. This was the first death in South Carolina related to MISC. We currently have another child from Greenville right now in our hospital who is severely ill. So I tell you this to not scare you, but to raise awareness about this condition and that it is a potential complication of having COVID. The numbers correlate to the prevalence in the community. So every time we see an increase in the numbers of COVID, about 2 to 4 weeks later, we start seeing more children with MISC. And that, Dr. LaCroix, I'm sure, has seen the same thing, that right now we have a lot of children over time with MISC. So at least 2 children in the hospital at a time with it, and it's very serious. So far, all of the children at MUSC have recovered, but I don't know if they're going to have long-term complications or not. I'm hoping not, but we don't know yet. Any child at any age and race and ethnicity can get MISC, but the majority of children are African American or Hispanic. So another couple of interesting facts about children and COVID is that they can transmit the virus even if they're asymptomatic. It is true that younger children, particularly those 5 years of age and younger, are less likely to get infected and less likely to transmit the virus. There's a lot of reasons that we think that this is true, but it is seemingly true. What will happen if the variants become the circulating coronavirus in a population? We don't know, but at this moment, this still is true. But there's important things to understand that matter in terms of whether a young child is going to pass it to other people. One of them is time. So when you're in a household or you're in school all day long with somebody without a mask on, that child is much more likely to pass it on to other people than if they had a mask on and were a little bit distanced from the other people. So all of these slides that I have links to the primary sources, and I'm happy to share these slides. They actually link to the articles. And this was a case in a childcare setting where 12 kids in 2 childcare centers did not have symptoms, but went on to infect 12 adults. And one of those adults did require hospitalization. So if you do the math a little bit and your denominator increases, it is very possible that a child in the schools with COVID could pass it on to their family member or somebody else in school if we're not careful with our interactions. We did see this at the beginning of the pandemic, some very not great stories in terms of how school was going to look when we opened. So these all came out in the middle of the summer before Charleston County or Greenville County had opened. And these made me very concerned about opening in person, because this was, in my mind, what was going to happen when we opened. But what we have found with time is that there are reasons that these places did not do very well. The one on the top, when you actually look at the article and really find out what happened, versus just reading a newspaper article, for example, the classrooms were very crowded. There was no physical distancing. There was a heat wave going on, so they made a face mask exemption. And there was continuous air conditioning without good filtration. And I think that is those conditions together really caused this problem. The example on the bottom is a Georgia summer camp. But you have to understand that those people were sharing close quarters and spending the night together. So instead of them being schoolmates, they were essentially household contacts, which is why in a household, you have the majority of people who get sick. Not everybody, but the majority. So these, in retrospect, probably were not the great examples of how school has opened and opened safely, but this is all we had at the time. So I was very nervous when school opened and thought it was going to be a disaster and that we would be closed in 3 weeks. And I told everybody this, including Dr. LaCroix over here, and I was wrong. And I am fine being wrong, because I wanted it to be successful, even though I had my doubts. And so at that time, we made a lot of jokes about opening schools, not opening schools. But what we know at this point is that it is really not a joke. And more and more evidence is coming out that children who are at home trying to do virtual learning are doing very poorly. And I think that we'll have more and more data on this as the months go by. Kids feel very isolated at home. It's a lot of burden on the family. We have seen anecdotally and now by research that children are having more suicide attempts, they're having more suicidal behavior. We've seen a lot of gunshots in our PICU since the beginning of this pandemic. Some of that is related to the fact that children are not always supervised when the parents have to go to work. Not everybody puts their guns up. And we really have seen this, accidents and suicide attempts. The other concerning data that's starting to come out is that we're seeing a decrease in child abuse and child neglect. It's not because there is not child abuse and child neglect. It's because a lot of that reporting goes on in the schools. And so if they're not at school to notice the bruise or to notice abnormal behavior, they go unreported. And what we're finding is that by the time they present to the hospital, they're much more severe cases than in the past. And I'm sure you know the educational data much better than I do. But the South Carolina Education Oversight Committee has presented new findings that show that 70% of South Carolina students in grades 3 through 8 are not projected to meet grade level proficiency. People are deeming that the COVID-19 slide. And it will continue to get worse with time if we don't get our children back into school. There's lots of other things that you all know go on in a school. People get hot meals, children get vaccinated, they get health care. And of course, there's the socio-emotional growth and development. And unfortunately, the children who are very vulnerable and already are at a disadvantage for a variety of factors are the ones who are suffering the most. So again, I try to put a little bit of humor in all of this, although we all know that none of this is particularly funny. But it really does set up a conundrum. Do you send your child to school? Do you continue online? Do you homeschool? Nothing is perfect, but what we have found is that kids need to be in school. And so I'm going to show you now what CCSD has done in partnership with MUSC and some of the data that I've been going through over the last couple of months. And I've looked briefly at the Greenville County School District numbers as well, and they also look quite good. And I have offered to come back after looking at the Greenville County numbers a little bit more closely, so that I can give you more specific data for your district. So CCSD, like many schools in the middle of the summer, said, oh gosh, the pandemic's not going to be gone by the fall. What can we do to open safely? And MUSC had developed a program. It was originally designed to open businesses safely. And it involves people physically going into the space, looking at what people have put into place for risk mitigation, and helping them a little bit to improve those risk mitigations. And so when the schools were supposed to open, the schools came to MUSC and said, we'd like your help in opening. And so initially I was involved in the schools just through DHEC and my hat as a pediatric infectious disease physician. But at some point I became formally involved with the Back to Business program because it didn't make sense for multiple people to be doing sort of the same thing. And so we've connected together. The program is not at all designed to make money. It is a very small fee just to offset some of the time that it takes to offer this service. And as you can imagine, this takes many, many hours of time to go physically into a space and essentially write up what works and what isn't working. And then the ongoing service of investigating cases and risk mitigation, et cetera. So it is a very timely endeavor. But what has happened is in this partnership, and we've worked very closely with the Low Country DHEC as well, we have put into place a very nice system that is constantly adjusted based on changes in the data, changes in maybe the timing of what sport is going on. And one really important thing that has helped me to share these data with you is that in the summer when the schools were closed, the nurses wanted to help and they reached out to DHEC and said, can we help you with contact tracing? And very few people turned down free help. So DHEC said, certainly. And the DHEC staff trained the CCSD nurses on how to actually contact trace. And for the summer, they contact traced for DHEC. And then when school opened, they became the contact tracers for the school district. So this is a very coordinated, well-trained team of 8 full-time nurses. This takes a lot of effort and time to contact trace, particularly when you have a large number of cases in the schools, which are typically related to the community numbers, which you'll see here in a minute. We also, at some point early on in the semester, helped the school do in-school saliva testing, which was a PCR-based test. The saliva testing is not great, but it's better than the antigen test. And so that was just another layer that helped the schools. I hosted a number of discussions with the families, community leaders, the schools, to try to help people understand what was going on and help people with buy-in, if you will, because this takes a very concerted effort on the part of not just those who go to school, but people in the community as well. So if you look on the left, that is the state of South Carolina when we opened in September. Greenville was still in the high disease activity level. Charleston had just recently gone to the medium level. That was based on 3 factors that I won't get into, but just gives you a little bit of a sense of what was going on in the community at the time. I felt at the time that the numbers were too high to open, but the school really wanted to get them back in school. And luckily I was wrong and it went exceptionally well. And so I'm going to show you those data now. So about 70% of the students went back in person 5 days a week. Some of those students who didn't go back didn't want to go back for a variety of reasons. And there was a space issue at that time that they are working on still, which I am sure that Greenville is working on also, because one of the biggest risk mitigators is physical distancing, and sometimes schools have challenges with that. There were about 6,300 in-person staff, and those I've only included those who were physically present in the school buildings. And you can see a little bit, those are teachers, janitorial staff, the nutrition, basically everybody. And it was 76 schools plus 2 centers across the entire early Head Start all the way to 12th grade. So I'm not going to bore you with this, but it is here so that you can review this later. I included every single case that was in existence in the schools. DHEC reports those to our schools. Even when the families don't say what school they go to based on where they live, it still gets reported. So this is a very accurate number. And there was some self-reporting as well. So that was cross-checked with the DHEC reporting. So anybody who had a positive test during this time, including several days after the semester, if they potentially were infectious while they were at school, I have included in these numbers. So in total, there were 497 cases, which out of the entire number of in-person staff and students is about 1.3%. You can extrapolate a little bit from the community. That is much lower than the community numbers. If you look at just the students, it's about 0.96% of the students. And the staff made up about 202. They made up 202, and it was about 3.2% of the total in-person staff. You can see that it wasn't all, a handful of schools that had the cases. They were pretty evenly distributed across all of the schools. And in fact, there were a number of cases, number of schools that had no cases at all. And obviously, as the numbers increase in the community, the numbers increase in the school. That doesn't necessarily change the risk of those students at school, but there is probably a level at which there are so many cases in the school that the contact tracers can't keep track, or you have a tipping point. I don't know what that tipping point is. I hope that South Carolina is past that tipping point as we see our numbers go down. But it is important to know that the total numbers in the schools are going to increase. But what is most important is the transmission in the schools. And so I looked very carefully at this, and I know that it is hard for people on the other side to understand why every school district can't give you these data. But this has taken me hundreds of hours to compile, because the school district, any school district, when they do contact tracing, their goal is to figure out who is positive, who was close to that person, and get them out of the school. That is their goal. Their goal is not to necessarily look at this as a whole. But I've had the opportunity to do this because the contact tracers had pretty good records. But it gets very hard. So you can imagine some kids and students are at multiple schools. So where do you count them? In Charleston County, they've counted them in both schools. So it often looks like the numbers are much higher than they really are. But the risk or the balance is, if you only report them at one school, then the other school feels like you're not reporting properly. And it takes a lot of time. So you can't really put them necessarily with asterisks, for example, to say one kid was at 2 schools, because then at some point it becomes a privacy issue where people can figure out who the children were, for example. So in Charleston County, they have casted a wider net, which makes the numbers look higher than they really are. In other circumstances, some districts have put in virtual students in the same group as in-person students, which I understand from a denominator perspective is very hard. But sometimes the reason for that is because the virtual students still go and do sports with the kids who are in person. And so it is very challenging for all of the school districts to report in a way that is helpful to the community. And it is not possible, I think, in most cases to do what I have done. I'm a researcher, and so I knew how to do this and have spent a long time doing this, but there is so much to learn from these data. And again, I'm not going to go through every number, and I'm not expecting you to look at every number, but I'm going to have these for you so that you can look at them more closely. The important things on the slide to appreciate is that the age range was across the board, from the early education students, the 2-year-olds, all the way to 18. The majority of staff reported symptoms, about 65% of the children reported symptoms. That doesn't necessarily mean that the rest of the students didn't have symptoms. What we have found at MUSC is that many times the symptoms are not recognized as COVID symptoms because they are so mild. So my child, for example, had COVID in December. She had one temperature of 100.2 rectally, and that was it. So sometimes these kids really do have symptoms, you just don't know it, or you don't appreciate them as COVID. And that is important, and we'll talk about that in a little bit. Other important things to take from this slide is that because the contact tracers recognized the close contacts and got them out of the school, that some of those kids and staff developed symptoms after they were in quarantine, sometimes to the point where they were not even infectious while they were at school because they were taken out of the school so quickly. And so that is one level of risk mitigation, is the quarantining. It's also important to know that there were many kids and staff who were in school for multiple days with symptoms and never were tested until later, either because they thought they had allergies, they thought they had a cold. In some cases, unfortunately, the parents knew that the children had symptoms and chose to ignore them and sent them to school anyway. Thankfully, that was a minority of cases, but it happens. And to do that puts everybody at risk. But you can see it here now in black and white. The good news is that because we are physically distancing and wearing masks, that the number of close contacts are very low. And so among the students, 76% had no close contacts. So that is huge because that keeps everybody else in school. When you have close contacts, those people have to go home. And you can see that for staff, for example, most of their close contacts were not necessarily students. There was a little bit of a breakdown, among the staff, but of the students, the majority of their close contacts were students, not staff. And again, that makes sense, and it is helpful because that lowers the risk for the teachers. So again, I'm not going to go through this whole thing, and I'm going to share it with you after so that you can look at it more closely. But I was able, in many cases, to figure out who the infection came from. Again, the contact tracers don't always collect the data, or the data are not always known. And it's again because their job is to get those kids out of school and to figure out who was close contact and get those kids out of school. So many times they just didn't write it down, or in some cases the families just don't know. But when you do have a source, in the majority of cases, they were from outside of the school. And out of 137 children, I was able to find that the exposure was actually out of school. We are having a lot of problems with sports. And what we are even finding more now is it is not the sport. It is what people are doing before and after the sport, carpooling, going out to eat, having sleepovers. And so if people want to have their children in sports or stay in school, we need to do better about what we do outside of the classroom. And you'll see here in a minute a little bit more of that breakdown. So if I looked at just those that looked like they may have come from in the school, there was very small numbers, 11 students, 3 staff, and 19 in total. And I'm going to share those a little bit because I learned so much putting this together. There was one case of close contact with a symptomatic student that infected a teacher, and I've just recently found that. But the key to that is the close contact, because I don't know the nature of why they were physically close together, but the opposite of that is to show you that if you maintain physical distance and wear a mask, that the risk is obviously very, very low to teachers and staff. Likewise, there were two symptomatic teachers who look like they gave it to students. And in both of those cases, there was close contact reported. And you'll see again in a minute here, then why the physical distancing and the other risk mitigation is so important. It's so that you don't have these transmissions in schools, because this is why schools either work or they don't work. It doesn't really, in my opinion, matter to a large extent what the numbers are in the community if you're being safe at school. So then there were a couple clusters of cases, and I'm going to go through them quickly because they're very complicated, but there's a couple key take homes. So this was a symptomatic teacher. Well, she developed symptoms. So I just say that she had symptoms, and she wasn't symptomatic while she was at school. But I'll tell you why it matters is because a lot of times people think they understand the direction that the transmission goes in. And in many cases, you cannot actually tell unless everybody develops symptoms and you know the exact date that they develop symptoms. So if person A develops symptoms on a Monday and person B develops symptoms on a Friday and they've had close contact, then likely A gave it to B. But if you have one part of that party that never developed symptoms, or you are not able to really feel good about whether they had symptoms or not, you cannot always tell which direction the transmission is going in. And so in this case, there were two asymptomatic 2-year-olds from two different classrooms, and the teacher floated between those two classrooms. At the same time, that teacher had household members who also tested positive and were asymptomatic. So we sometimes talk about the PCR, and so I have just put this up for you to look at a later date. The PCR is very, very sensitive. It is our gold standard. At MUSC, it's about 99.5% sensitive, meaning that if you do 1,000 people, maybe one you don't capture that is really positive. Sometimes it depends on how well you collect the sample, what media you transported, and it's very complicated. But in almost every case, if the person has virus in their nose, you're going to detect it. And so what happens is that sometimes you are detecting virus not at the time that they're infectious. So if person A has symptoms on Monday and then say 14 days later has a test and it's positive, that means that they did have COVID, but they're not necessarily infectious at the time that they had their swab. But you don't always know, because many kids and adults don't have symptoms. And so you are often guessing as to whether they are infectious at the time of their positive test. So when people talk about false positives, that's usually what they're talking about. They're not false positives. Those are real tests with accurate results. It's just that the timing of their actual infection sometimes is not known. So in this case, it is hard to say whether one of those infants gave it to the teacher who then developed symptoms, or if the teacher gave it to an infant who just never had symptoms. And again, this matters because there's a lot of speculation as to who gave it to whom in various settings, or who's at fault, or a variety of other things that we hear about. The biggest thing is that if you maintain physical distancing where possible, you're going to decrease those transmissions. Now, obviously, in 2-year-olds, you're going to have close contact, so it's not always possible. But I share this example to show you how hard it is to figure out who the index case is and who's infectious at the time of their positive test. And we certainly can always talk more about that if you have additional questions. So here's cluster 2. I did this morning because I had such a hard time even putting it in words to explain to you how complicated this is. It extended over one grade in one school and affected 5 classrooms, and there were positive cases in all 5 classrooms. And it looks like, oh my gosh, we've got to close down the school. Everybody's infected and everybody's infecting everybody else, and it's all happening at school. But when you really look at it, that is often not the case. So in this example, the teachers who were infected, one teacher gave it to another teacher at a party that occurred outside of school. And a lot of those children not only were in school together, but they were together outside of school, either in their extra, their after school program, or many were best friends outside of school and had sleepovers, spent a lot of time together. So if you think about the time together and your infection risk, it goes up the longer you're together. And so chances are those children actually got it outside of the classroom, not inside the classroom. This story got very complicated because there was a substitute teacher who didn't maintain physical distancing, and things went a little haywire. And there were at least 2 students that I think did get it from the other positive, most likely the students rather than the teacher. But because most of those students were asymptomatic and the teacher was symptomatic, the community really went hard on the teacher, saying that she had given it to everybody. And I really just don't think that was the case. I think in many of these students, they acquired it from one another. And many of those cases were actually outside of the classroom. So again, I tell you this because this matters for what you do in the classroom, and it matters for what you do at home. When you think to yourself that, well, I'm in their classroom anyway, so why can't I have them come over as a sleepover? This is why. Because luckily the school break happened and the school was closed, but this would have resulted in the entire grade being closed, and all of those kids would have had to go home and have virtual learning. So I am not going to spend tons of time on all of the risk mitigation. We can talk about it on another time, but we all know now that it is a layered mitigation approach. So for those of you who have previously worked in factories or companies with safety issues, the Swiss cheese approach is not something I created. This is a well-known philosophy of the more layers of risk mitigation you put into place, the less chance that you're going to have of harm. CCSD also did just remarkable things over the summer in terms of updating their facilities. Some of this had gone on for decades of updating the facility, but a lot of this happened over the summer, and have a very coordinated approach. Anytime there's somebody who's positive in the classroom, they fog the room. They have really gone to great lengths. So I'm going to talk a little bit about masks. I understand that nobody loves masks. I will be happy when the pandemic's over and we don't have to wear masks. But it is by far if you cannot maintain 6 feet of distance from somebody, it is your number 1 risk mitigator. Masks work. So there was a lot of confusion early on in the pandemic, and things have changed, but in terms of what perhaps we thought then versus now, but it is very clear from the literature now that masks work. So we have data from before COVID. So for my colleagues here, we have always had masks and gowns and gloves on for infectious individuals when we go into a room and we are less than 6 feet from these patients. When I was younger in training, it was 3 feet, and it actually changed at some point to 6 feet. These numbers are not made up. Sometimes people will say, oh, well, it's made up. It is not made up. It is based on how far droplets spread. And so if you sneeze, you see the woman up there, that is what happens. If you have little kids and they sneeze on you, you know this is what happens. You get very wet. So the majority of droplets go 3 feet, and then the rest of the droplets go 6 feet. There are droplets that go farther than 6 feet, but almost all of them go that distance. And so that is why we use 6 feet. COVID gets very complicated because there is some element of droplet suspension, and and that gets, into the weeds a little bit, but if you have a mask on, you are going to prevent your own droplets from spreading onto other people. And so what we know now is that when both people have masks on, there is just an increased level of protection of that droplet spread. So they've done a lot of studies now. These masks, these cloth masks, they're not perfect. They do have escape on the sides, but the majority of the droplets that come out the front do not come out. And in some of these studies, even a single layer bandana helps. We do know now that 2 and 3 layers is better, but anything is better than nothing. So if you have 6 feet of distance and masks in between 2 people, your risk of transmission is virtually zero. And this is your number 1, number 2, with hand hygiene, your biggest risk mitigator. Nobody loves masks, but I'm going to show you data. They are safe and effective, and they do not interfere with a child's development. So that is my child there at camp. And you can see they really, if you treat it as just a normal thing, they get used to them. Sometimes my child, when I pick her up from school, she forgets to take off her mask because they're used to having it on. And it's just become our normal way of life, at least until the pandemic's over. So we in pediatrics think that any child 2 years of age and over should be wearing a mask and can do it safely. So we have no evidence that they are at all dangerous. We've even done studies in adults with pulmonary problems where they have problems at baseline. And when you measure their CO2, it is no different whether they have a mask on or they don't have a mask on. And those are sick adults. So in a little child who is healthy and you have a breathable mask, where you already saw from the demonstration in the previous slide that you have air that comes out of the sides, they're going to be just fine. And in fact, when we do exercise testing, you essentially have a mask on. And so those are athletes, and they do just fine. There are some very rare exemptions if you are not cognitively developed enough to take the mask off. That's why we cut it off at 2. Or if you have significant facial injuries where it would be a problem. Otherwise, you should be wearing a mask. So there's a couple things that have worked very well in CCSD. As I said, the contact tracing has worked very well. The physical distancing, the student cohorting, and part of that is having an up-to-date class roster, bus roster, so that you can quickly identify who's been exposed and get them out of the classroom. Of course, it has taken some very creative solutions on all of the school districts, and I know Greenville has done this as well. Repurposing existing space, trying to maximize outdoor space. Luckily, we live in the South where it tends to be warm, where you can put up tents and other things and increase your space. I always like the picture in the upper right. So that was an LA Times article. The title was How Little Kids Don't Get the Virus. But when you read the whole article, very deep buried into the article was that they were physically distancing and wearing masks. So yes, it's true that little kids probably don't get it or pass it as much. But the reason that LA was doing so well and hopefully continues to do well is because of the risk mitigation that they had in place. So it's not a coincidence when a school district is doing well. I think having easy access to testing has really helped a lot of school districts, including CCSD. I'm amazed sometimes at how creative the schools have gotten. Some families do not want to be in school, and they should be given the option of a virtual alternative learning. And for those kids who have to be isolated or quarantined, you need to have a seamless transition to virtual learning so that things can continue. And in the schools that I've seen that have done this, they've done very well. So you see the Pentagon on the right. This is what the typical setup looks like in CCSD. The important thing to understand about this is that the CDC considers close contact 6 feet, less than 6 feet, for greater than 15 minutes. And even now they continue to use that. South Carolina DHEC allowed something very early on that initially I was very worried about, because we did not have a lot of data whether it worked or didn't work, but it appears to work, is that if you have a child who's at least 3 feet separated from another child with plexiglass and masks, those do not count as close contacts. And they don't have to be quarantined. So when you get rid of the plexiglass or you get rid of the mask and you are less than 6 feet away, if one child gets infected, that whole pentagon or the whole classroom is going to have to be quarantined. So this is a brilliant solution for not only risk mitigation, but for decreasing the number of close contacts and the number needed to quarantine. When we opened in the first part of the semester, we did not have any data that this was going to work. And it made me very uncomfortable that we were going to see transmissions across the Pentagon. And I have no evidence that that is the case. So not only does it decrease the number of quarantines, but it does seem to be effective in preventing transmission. This allows more children in the classroom when you have this set up. You can see, if you look, I thought I had a pointer, but I don't have a pointer, that the plexiglass extends beyond where they're sitting. And that is very key, because I have seen some other setups where it's actually shorter than the desk. And obviously that is not as protective. So I understand that not everybody likes masks, not everybody likes the risk mitigation, but I have spoken to many of my developmental pediatric colleagues and looked at the data, and we have no evidence or concerns that this is impacting children. They are much more impacted when they're at home doing virtual learning. So you can see in the upper left, this is a recent article that showed that out of over 1 million children in China, that wearing masks actually decreased their anxiety and distress, because they probably felt safer. And if you go to the bottom right, they did a really creative research where children tried to decide what your emotion was with part of your face covered, and they were still perfectly able to determine what your expression was, even with a mask on. Do we want to get rid of the masks? Yes, at some point I would like to get rid of the masks, but it allows our children to stay in school and to be safe. That is my child again, showing the chin diaper. That is how you do not wear a mask. And my wonderful older sister sewed that, but it just didn't fit. So fit is really the most important part of the mask. There's a lot of discussion now about double masking. I never discourage somebody from double masking, but it is more the fit that matters than the double masking. There are some things that are higher risk than other things, and sports, choir, band, they're high risk. If you want to do them safely, you have to wear a mask and space appropriately. But again, the activities around the sports really are the most important part. There were several clusters of sports in my data set that I'm not going to show you today, but one student, for example, carpools with one coach who's infected, gets that one person infected, and infects multiple people on the team. Some of that may occur on the court. Basketball has been a very high risk, problematic sport. It improved once we decided to put on masks. And that makes sense, right? Because you've got a lot of droplet spread in basketball. In no way am I saying not to do sports. We just have to do them safely. Sports has evolved greatly over the last couple months. Even as early as December, I was concerned about the risk on the court for basketball. And even in the last month, we've had new data come out. If you've seen the MMWR from the NFL, that is so telling of what really is going on. So if you haven't looked at it, you should. The NFL obviously has a lot of money. They were doing PCR testing 7 days a week. and they had little trackers on everybody that could determine how close you were to other people, for how long, and who those people were. And what they found was that those outbreaks occurred outside of the actual sport. They occurred carpooling, having meetings in closed spaces without masks, and having meals together. And it is the same as we found now in our younger children. So a couple of other problems that I've kind of mentioned is that people are going to school with symptoms. We've got to do better about staying home if you're symptomatic and getting tested. Sometimes people think they have allergies, and they may have had allergies for the last 20 years, but not all symptoms are allergies, even if they're similar to your normal allergies. So I really push schools hard that even if there's a doctor's note that says they don't need to be tested, that if in their clinical judgment they feel that they need to be tested, they get those children tested. And in many cases, those children have actually been positive. So you cannot look at somebody and just decide, unless it is very cut and dry, where they have asthma, they do an inhaler, and then they're fine. Otherwise, it always could be COVID. We have tried to do the shortened quarantine periods and really have struggled. And I'll show you data here in a minute. So to my point about the mild symptoms is we do a lot of temperature screening, and in the older kids, only about 35% even have fevers. In the younger kids, maybe 46%. So you cannot use fever as a determining factor. Diarrhea, stomach pain, and headache. Headache is a very common symptom, and sometimes is the only symptom. That teacher who was at school and was symptomatic, and all of the classrooms had positive cases, she was in school for 2 days. Her only symptom was a headache. And people get headaches, right? And I'm not suggesting that you need to get tested every time you have a headache, but if headache's unusual for you, or you otherwise are not feeling well, you have to think about COVID. I mentioned the quarantine period. 14 days is not made up. 14 days is the number of days where 99% of people will develop symptoms or develop COVID. There are still some people who develop COVID after 14 days, but it's a small number, and that is why we've chosen 14 days. So the CDC has made shortened quarantine recommendations, and in certain circumstances, they are reasonable. The 7-day period has not worked out very well for CCSD. They tried it early on, and they had at least 3 cases of students and teachers who came back after 7 days with a negative test at 5 and ended up developing symptoms and developing COVID. And one of those teachers actually gave it to a student, and that was one of those close contacts. So they changed their policy and now do 10 days plus testing at day 7, and have stuck with a 14 days for sports because of the higher risk. All activities have a different risk level. And so we constantly have to assess where one risk is higher than another. And this sometimes changes a little bit based on what we learn. So the greatest risk are the high risk activities outside of school, as I've mentioned. This tool in the bottom right, the link is on the bottom. It is fascinating. You can click on it, put in what your number of people you're around, and based on the prevalence in your community, it gives you the chance that one person in your party or your gathering or your sleepover is positive. And it's a rude awakening for some. So in conclusion, I will reiterate that children really are suffering from not attending school in person. We need to put them in school. Transmission is low in schools if we have the appropriate risk mitigation in place. Activities outside of school really have been shown time and time again to be the main driver of transmission and cases in schools. We need to do a better job of getting buy-in from everybody, because what you do outside of school matters. And if you can convince people that the way to keep people, children and students and teachers in school safely is to be better outside of school, I'm hoping that with time, people will understand that if they want their children to be in school. So I am going to stop. I'm sure you're tired of me talking. And we were given a number of questions from the school board members, and I am going to read them out loud, and then my colleagues are going to help me answer them so that I don't have to do all of the talking. So I've grouped them because you'll see we received 6 questions, and they each one kind of went well with another question, and so I've grouped them that way. So Dr. Stiles asks, as infectious disease pediatricians, name the one point that you would have us remain cognizant of during this pandemic as we advocate for our students, teachers, staff, and community. And Ms. Goodwin Caldwell says, there seems to be a correlation between the community spread being high and the student, faculties, and staff contracting it. Why should we not go back to attendance plan 0 or 2? The students, faculties, and staffs live in the communities, and if they are partaking in activities that are risky, isn't that risky for our district spread? I can't remember now who I assigned it to. One of you. I mean, I can certainly help answer them as well, but I'm going to turn it over to Dr. LaCroix.
Sure. So, I think in terms of our obligation to the community is to help them understand the importance of masking for the community. And it's the same thing that Dr. Blackstone and Dr. James have sort of brought forward, that the community can really impact their own community spread with masking, social distancing, good hand hygiene, just basic blocking and tackling for controlling epidemic spread. So I think the messaging that the community begins to see state rates are decreased. I heard this morning DHEC outlining those rates, and people go, oh, maybe we can stop. It's like, it's not time to stop yet. It's time to continue to focus on masking and to focus on the things that we know physically give us a barrier to protect us. Vaccine rollout is going as quickly as they will distribute it to us. And again, I think the entire country is struggling with vaccine supply. And Dr. Blackstone, I don't know if you want to weigh in on all of our struggles to get more vaccine.
Sure. So, it's more important than ever to continue what we've been doing to see the decline, with mass hand hygiene and social distancing. As Dr. LaCroix said, Dr. James and I have been talking about this almost a year now. As we look at the vaccinations, we are. I mean, we're given every vaccine essentially that that is being made available to us. Unfortunately, that supply is waxing and waning, and the quantity is waxing and waning. And, so we continue to work with DHEC. They continue to work with, the CDC to look at streamlining, the different vaccines and the quantities that we're able to receive. But it's going to take a little while to figure out and to truly see the vaccine effect. We started this second week of December, so we started giving our first vaccines. And, so we're not that far out from it. And, people are doing well. You had 3 groups. You had those that were on board quick. You had those that did what we call watchful waiting. And then you had the ones that said no, never. Well, as we've been doing this a little while and people are realizing that, people are tolerating the vaccines with very little difficulty, we have people who are starting to warm up to the vaccine. We've done a lot of education, and I know, Prisma's done, the same thing I'm sure MUSC has, about trying to educate our physicians, our employees about the safety. And now we've got a direct focus on the community and certain vulnerable populations in the community who tend to step back and they're scared to do it. So part of our job now is to continue to encourage people to take the safety precautions at the same time, to help educate them and encourage them to get the vaccine.
I would add as well that vaccine is just one layer of protection. We don't know yet if being vaccinated prevents you from transmitting the virus to others. What we do know is that it prevents you from dying of COVID, but there is a risk until we have more data that you could acquire COVID, have small levels of virus, and still pass it on to others. So there's more questions about the vaccine in a minute, but the point to that is just one of many things that we can do. We still have to wear masks and physically distance. Even if everybody is vaccinated, until the community levels are so low as they were when we started this pandemic, until we get to that place, all of the risk mitigation still has to be in place. So as much as I would like this pandemic to go away, it is not going anywhere that quickly. Our numbers have certainly decreased, but we see, based on what happened over the holidays, that they can quickly increase again. We don't know what's going to happen with these variants. I am hoping nothing, but there is a risk that these or other variants that are evolving as we speak may change the whole pandemic. So we collectively, as people in South Carolina, in Greenville, and Charleston, we all have to work together if we're going to get out of this and keep everybody safe and people in school safely. To the second question, I understand the concern there. And as I said, cases do go up as community numbers increase. That is absolutely true. So the lower your community numbers, the lower your rates at school, and the more safe you're going to be. I mean, that is the fact. But when schools do what they're supposed to do, and everybody buys in to wearing masks, physically distancing, and all of the many layers of protection, people are safe at school. And where we see the problems are when people don't follow the rules or things slip through the cracks. And so we just have to be cognizant of what's happening in the community, what's happening in schools, and we adjust. As you have seen from my data, we changed things as the semester went on. We postponed basketball for a while because the numbers were so high. So it is an evolving thing. Something that may be true in December may not be true next December. And so people have to be willing to adjust a little bit as the pandemic evolves. I'm going to move on to the next, unless you guys. Okay. So this is a little bit to what I was just talking about, but Mr. Lewis says, it seems that much of the evidence supports the idea that children are less likely to spread the virus than adults. Much of the precautions we put in place were to help protect the staff who were uncomfortable returning to confined spaces. Educators are currently in vaccine group 1B, which could ensure staff receive the vaccine this spring. If those vaccinations go well, would you support lifting any of the following COVID protocols for fall? And then he lists a number of protocols that are currently in place. And Mr. Saylor says, how well will the vaccine protect staff, and does it offer protection against any spread as well? So I'm going to have them answer. We've talked a little bit about it. The only thing that I would say is fall, even though it is kind of right around the corner, a lot can happen between now and then. So my personal feeling is that it's just too far away to really know what's going to happen in the fall. My best guess is that risk mitigation is going to continue throughout the next school year. If everybody gets on board and does what they're supposed to, it's possible that by the end of 2021, our numbers will be so much better that some of these things can be lifted, but a lot remains to be seen. I'm gonna see if you have anything more to add.
No, just to echo the same. It's so very early. The variants and their prevalence of circulating, and we're learning about a mutated virus. And so as more science evolves, I think that direction will continue to evolve. But I do agree. I think that the basics of masking and distancing and hand hygiene are going to continue to be our best protection as we move forward into the next school year.
So Dr. Eckard's already answered Mr. Saylor's question. So we don't know if it protects against the spread of this, the spread of COVID. What I will focus on is the vaccine in and of itself. As you know, Secours is working with your school district. We'll have a plan, your vaccination plan done, we think at the end of this week. If you look across the country and you look at the numbers, in an ideal world, we'd have 100% vaccination. We don't have that. We struggle to get people to take the vaccine. 8,000 of the school district employees have already said, I want the vaccine out of 11,400 something. That's an excellent number. So you have an excellent start from a vaccination standpoint. When we were told that number, we were pretty excited about it because, most people sit somewhere between 40 and 50% when you look across all employees, in the different groups. So at the end of the day, but the importance is we still have to keep doing what you're doing. Like Dr. Eckard said, the fall's a ways away. A lot of things could change, and we just don't know what kind of effect vaccination is going to have at this point.
And I'll just echo that the pediatric clinical trials have just started, and the youngest groups have not yet started at all. So the two components, both the pediatric community and the adult community, are going to be at different places in terms of vaccine implementation.
The other variable is we are still learning about reinfection. So as pediatricians, Dr. LaCroix and I have dealt with non-COVID coronaviruses for many, many years. It is one of the common viruses that cause colds in children. And there's a couple different varieties of coronaviruses. And just like most viruses, they mutate. And we are now starting to see, because this pandemic has gone on so long, it's rare still, I believe, based on the data we have, but that there have been reports now of reinfection. So we don't know how long protection lasts. We don't know if there's certain people who are more likely to be protected than others. It's not based on what kind of symptoms you have. It's very complicated and much that we don't know. So as this pandemic continues longer and longer, and we have more mutations in the virus, this may go on a long time unless people really work together to get the numbers so low with vaccination and with risk mitigation that we can have some more control over the virus. One interesting thing that has happened in the last year, and you can find these slides on CDC. I should have added them, but in the interest of time, I didn't. The influenza this year, our para-influenza, our RSV, which typically goes rampant in the fall and in children can cause a lot of morbidity and mortality. We have not even barely seen cases this year. And if you look at the CDC website from this year compared to last year, it is so amazing. And I know anecdotally we've seen this too. I haven't seen a single influenza case yet among our pediatric admissions. It's because the masks and the physical distancing work. And it is something that we have to do to get through this. And I mean, I do hope that the variants won't adjust this too much, but we are learning more and more now that the South African variant is very prevalent in South Carolina. We don't know yet how prevalent, but it is here. So it tends to be a little bit more transmissible than the original strain. And so there are implications there. So we just have to stay vigilant. And then the last set of questions, Ms. Doolin says, I'd like to hear what the reason is that students are not transmitting COVID to each other or their teachers. If it were only masks and plexiglass, then we would expect to see similar numbers of transmission across all school age groups. And this doesn't appear to be the case for all the studies we've seen recently. And if the younger a person is or the smaller their physical self is, then are they less likely to transmit? If this could be true, then are we doing more harm than good by keeping them masked all day behind plexiglass? And Ms. Mosley says, I understand that you are both pediatric infectious disease doctors, but with depression and anxiety hitting peak levels in our student populations, my larger concern is with mental health. Many in our community have expressed concerns that the excessive masking of children and setting up plexiglass barriers that prevent natural developmental stages from occurring is far more harmful to children long term. An example in our adolescent student population would be relationship building bonding stage that's critical during the 9th grade transition year. Studies have actually shown that there's a direct correlation to 9th grade experiences and dropout graduation rates. How much emphasis should be placed on mental health during our decision making, and who do you believe we should be collaborating with to ensure that we are providing developmentally appropriate environments that keep our children emotionally and mentally healthy? You want to start? You want me to start?
So, that's where some of the science that is really helping inform us on the fact that particularly young children are able to pick up cues. They're able to connect even with mask on, that they are so inquisitive into their environment that they can make those connections. So that's very reassuring. Again, working with the adolescent populations and helping them to understand, we know from the China studies that they do want to be masked. They feel safer from those studies. So I think that there's beginning to be evidence around this. One of the very, very crucial roles that the schools play is having psychology help and having counseling help in the schools. And so for the children that don't have as ready access to that, being in a virtual environment, there are, again, papers that are now being published describing that degree of depression, withdrawal, anxiety from being in an at-home environment and not within what children see as normal. What children see as normal is that they go to school. And so this is a very different environment for them to attempt to learn in the home environment. Just as if any of you have worked from home, you know how difficult that adjustment is from your home mindset to your work mindset.
So, although we are subspecialists, we are both board certified pediatricians and moms. So I care very much about the mental health and the mental well-being of the children. This is why I am doing what I'm doing. I have done virtually nothing but schools and COVID for the greater part of 9 months, with less focus on my regular job. And I'm not getting paid any extra. I just work more hours, and I do it because I care about children, and I want everybody to be as safe as possible. So that said, as Dr. LaCroix mentioned, everybody is suffering from this pandemic. And unfortunately, children are collateral damage. And we have to do everything that we can to improve their well-being and make sure that their mental health is okay. And we as pediatricians have known this a while, that kids are suffering, and it's just now that the data are starting to come out. But we have seen this for many, many months, that when they are at home, they cannot develop appropriately. You know, in this last spring, my 3-year-old was trying to do virtual learning. You know, I mean, we all know it's not ideal, and it was a disaster. And to Ms. Doolin's point, there is evidence that the younger kids do get it and spread it less frequently. And so everything that we do in life and everything that we do in COVID is a risk-benefit analysis. And there may be some things that we do in the younger kids that we would never do in the high schoolers because they're younger. And knowing what we know about COVID and knowing what we know about their development, but it all depends on where your risk level where you want your risk level to be. So I tell my patients, I don't like crossing the street if it doesn't say walk. I have patients that run out across 5 lanes of the highway and have no problem with it. So we have to strike a little bit of a balance. There are schools where the younger kids are masked, but perhaps are not behind plexiglass. Maybe because the school didn't have money for the plexiglass or they didn't want to do it. You know, every school and every district's a little bit different. The downside of doing that is that everybody's a close contact in the room. And so maybe this has happened to you, but my child had to be quarantined because one teacher floated between multiple classrooms, had COVID, reported being in close contact with the entire classroom. So everybody had to go home. So if you can cohort and keep the groups smaller, and that will decrease your amount of quarantines. If you can't do that and your group is bigger, then more people have to go home. So it really just depends on where you want to be. One kid can really quarantine all 30 kids, right? And so that's where the plexiglass and the masks and those things help. The younger kids are very challenging. The special needs kids are very challenging. And we have to be creative in how we handle those things. It is true there are many daycare centers that aren't behind plexiglass and have done great. And why is that? Well, I don't know. Maybe they're doing better at home and they're not going out. You know, the families are being more responsible. Maybe they just got lucky. But you can see from that elementary school, it only takes one kid. And if you're not cohorting, that it can spread very quickly across an entire grade. And so we need to balance the safety of the other students, the safety of the community, with the appropriate developmental implementation and mental well-being for the children. So I will also say that we are trying now to help the children more with mental health problems. And I put together a mental health mini series that will start in March with psychiatrists, with psychologists, child psychiatrists, with developmental pediatricians to address a lot of these issues. And I will share it with your district. And I think it would be a good opportunity for people in the community to listen to that. But we do know that kids at home do much worse than when they're at school. Kids follow your lead. So if you make it not a big deal to wear a mask and it's just part of everyday life, kids are very resilient and they will do it. If you make a big fuss about it and make a lot of drama, it becomes very dramatic for the children too. And anybody who has children can appreciate this. It is really how you handle it and how you present it. It can be fun. My kids actually, I walked in one day and my 4-year-old had all of her stuffed animals lined up and had masks on every single one of her kids. And she was playing school and she was having a blast, and she is no worse for the wear because she wears a mask in school. But she is so happy to go to school every day. So all of this is a balance, and kids can develop completely normally in the school setting if we are creative and work together. So I think that is the last question, and I'm gonna stop there. And I really do appreciate your time.
Well, thank you so much, Dr. Eckard. I mean, this and Dr. LaCroix and Dr. Blackstone found this very informative. I know our board members are very pleased that y'all were able to answer our questions and concerns and the future that is unknown at this point, according to statistics and so forth, because everything changes daily, monthly, and so forth. We're very appreciative of your work. We ask that you continue to focus on our children and our students in schools because they are our future, and we want to make sure that we provide the best environment and learning that we can under this pandemic and unknown troubled waters. So we thank you. I did get my vaccine today. I got Pfizer. Just wondering if I should have got Moderna. I just don't know. But I'm sure they're both
They both work.
similar.
They both work well.
Okay, well, good. I feel better. So anyway, with that, Dr. Royster, do you have anything? I know we were only allowed an hour, so we're very appreciative that we went far beyond that time. But do you have anything you'd like to add?
No, simply to echo our appreciation of Dr. Eckard, LaCroix, Dr. Blackstone, for your time this afternoon. You were most generous with it. We appreciate you sharing all that knowledge that you've garnered from the study of what's gone on in Charleston County and MUSC, and also Dr. LaCroix and Dr. Blackstone for you all lending your expertise as well. So thank you again.
I do have a question. Several board members wanted to know if we would have access to your PowerPoint presentation.
Yes, I'm happy to share that.
Okay.
And I am hoping to publish the data soon. If anybody's in research, they know it takes a little bit of time, but that will be coming as well. But yes, you're welcome to it, and I'll share that with.
I promise we won't publish it before you do.
Yeah, there's always a problem. But no, I'm happy to share it, and this really is what we are in medicine for, and dedicated to this. And I'm happy to come back and share whatever people want more information about. I have agreed to look at the Greenville County School District numbers. I've looked at them briefly. They look comparable to CCSD, but I'd like to look at them a little more closely. So I'm available for whatever you all need.
Well, I think we will probably have you back since you would come back. But I think it's important that we have Prisma and Secours here with us tonight represented, as well as MUSC in Charleston. So I think we have covered a lot with your expertise and knowledge. We thank you so much. I wish you safe travel back home to your family and the best to your children and all those involved. Thank you so much. And on behalf of the board, we all thank you. There is no action item taken. This is only for knowledge and information. So thank you. I now will adjourn. Now let's give them a round of applause.